This meeting is now being recorded.
I do ask though during this time when you're off mute that you keep your phones on silent or on mute unless you do have a question, so that again we can just minimise that interference from the various guests. So without any further hesitation, I'll hand over to Bob and we'll get started.
Thanks. Okay, I'm going to cover two things. I'm firstly going to do an update on the forward view, which is probably one of the biggest events in the NHS for this decade. I don't think I overstate that. I think Simon's done something really remarkable in terms of getting a consensus on the challenges facing the NHS, the need for new models of care, the need to up our game very substantially around prevention and health promotion. So it's really, I think, set the agenda for much of the rest of the decade. It's also, I think, enabled a constructive discussion around funding. So I make no apologies for focusing on the forward view. However, I'd then like to really just pick up some headlines in terms of the likely developments. What does it mean for commissioning? Take about half an hour and then very happy to pick up questions, challenges, whatever you want to. One thing I've said to the organisers, for anybody who may be either shy or thinks of a question afterwards, I'm very happy to pick up questions in the next few days via email, but I'd ask you to email your question to the organisers and then I promise to come back via them sometime next week. So sort of moving on. Forward view, just a bit of context. As you know, you can't have missed it. Published on the 23rd of October. Very much developed in partnership between NHS England, the regulators, Public Health England. So for the first time seeing an agreement across the key stakeholders of the future of the NHS. Coming out shortly afterwards what I think will be the very influential Dalton review around the future of providers, which I think needs to be read alongside the forward review. A lot of engagement of patient groups, clinicians and independent academic experts in determining it. So I think it gives a pretty robust diagnosis of the state of the NHS, the key challenges and where we need to go. And that, I think, has been very successful, which is what's remarkable, in creating a collective view of how the service needs to change, at least over the next 5 years, if it's actually going to close. The widening gap in terms of the health population, but also actually the funding challenges within the system. So, absolutely seminal piece of work. What's it about? Well, it's about actually setting out and building on that consensus around why we need change. But that doesn't achieve anything in itself, so it actually then goes on to say, well, what change might look like and how we could achieve it. And I think one of the most interesting bits of it and important is actually describing the various new models of care which could be provided in the future, and then going on to say, well, actually, how might we make those a reality? It very much isn't about actually letting 1,000 flowers bloom, but it is actually about saying there's a range of models which would provide joined up, high quality, affordable care, and we need to develop those and then roll those out. So I think the new models of care, really important piece of the forward view. But it also, of course, actually covers disease prevention, integration and so on. And it's about the cultural stuff. So not just new models of care, joined up care, more of a focus actually on disease prevention, but saying that consistent and high caliber leadership is going to be absolutely crucial across not just the health and care system, actually more broadly with local government partners, if we're all going to get the benefits of the forward view for ourselves and the NHS. I won't run through this in detail, but just to make the point that it's not a question of being critical of the NHS. Over the last 5 years, the last decade, we've made huge improvements in things like cancer survival rates, waiting times, reducing early deaths from heart disease. So it's not that we're lacking in progress, it's just that we face some really serious challenges. And we are delivering much, much more care. So practically in terms of patients and the public getting value from the NHS, there's no doubt that it's improved. But the big issue, of course, is that demand for care is growing rapidly, like all nations in Western Europe and the States. We've got issues around the demographics, which are all against us in terms of a growing number of older and frail older people. It's great that folk are surviving much longer, but one of the problems is that actually they're often surviving actually with multiple diseases. They're much more frail, so the dependency levels we know are growing. We've still got, despite all the best efforts over the last 30 years, 20% of adults smoking. We know about a third of people actually drink too much alcohol. And we also know that actually in terms of one of the consequences, liver disease, we commission pretty badly. If you go back and look at the Atlas of Variation on liver disease, it's pretty damning in terms of what we don't know around actually the provision of services, outcomes and so on. But a huge challenge both in public health terms and to the NHS. The whole issue around the obesity epidemic, long-term conditions now account for 70% of the NHS budget, and much of that spend is increasing on those actually with comorbidities. And people's expectations rightly are actually changing at the NHS, and we need to meet those if we're to maintain public confidence. So a big issue on demand. I'm not pessimistic because I think there are new opportunities, but we need to grasp them in the way that the NHS hasn't before, particularly around actually new technologies, our ability to predict and diagnose and treat disease, keeping people alive longer, but crucially keeping them actually alive with an improved quality of life. And one of the things that I find a bit depressing, given that actually telehealth, telemedicine is proven in terms to actually be effective with some patient cohorts and is now incredibly cheap, that we've not seen that actually that roll out across the NHS. It does tend to be still actually taken up in pockets. So big opportunities around actually changing how we deliver care. Crucially, we need to improve the coordination of care built around patients, and a lot we can still do around improving outcomes and quality, not just in terms of international comparators, but also actually, again, if you go back to the better value packs, the Atlas of Variation, really making inroads into the totally unwarranted variation in terms of clinical quality and outcomes we see across the NHS. And then on top of that, of course, actually rising demand and expectations create a huge financial challenge, estimated to be around 30 billion by the end of the decade. It doesn't matter whether it's 25, 30 or 35 billion. It's a big enough challenge that you can't solve incrementally. So, Forward View identifies 3 gaps in inverted commas that we need to address. One of those is around the health and wellbeing gap, and folk have been saying this, I guess, ever since I've been involved in commissioning, so for at least 15 years, that we need a radical upgrade and we need to put more effort and resources into prevention and be effective. Well, this is the time we need to do that if you go back to all the demand indicators. So we need concerted national action on the major health risks. We need to target prevention. For example, in diabetes, we've still got an increase in incidence. We've still got far too high a level in many parts of the country in terms of actually avoidable complications from diabetes. We're not doing that well. Part of the key to that is much, much greater patient control and actually, I don't like the jargon, but basically harnessing the energy, the resources in communities and in user groups. And we've not really taken a consistent, a concerted approach to that. So that's health and wellbeing gap. Secondly, the care and quality gap. Key thing there is new models of care. We're absolutely not suggesting that actually we go for a one-size-fits-all approach because we recognise that what's developed in one community may not be necessarily transferable to another. So we need to be sensitive to that. But equally, given the challenges the NHS faces, 1,000 flowers blooming doesn't feel appropriate either. So we're looking to develop a menu of new models of care for local areas then to consider and actually decide what's best to adopt given those circumstances, and to enable the move towards new models of care at pace by actually looking to address some of the blockages. whether they end up being funding models, approaches to contracting, enabling outcome-based commissioning, given that it's a COBIC webinar, but really addressing those potential barriers at pace so that actually local communities can then drive forward with whichever of the new models of care they actually in fact want to develop and introduce. But this is about doing things at pace because the time will run out. And then it's around the funding gap, need to drive forward with efficiencies as well as requiring some additional funding, and there's been a very positive response, I think, to that agenda nationally. So let's just focus on prevention. Well, we need to focus on prevention, we need to empower patients, and we need to engage communities. I won't go through these in detail. Some of the ones I pick out are very much around actually finding ways across government and within health and social care of incentivising healthier behaviours by individuals. Local authorities are the key to many of the actions around actually the determinants of health, so that's pretty crucial. Using actually the opportunity presented by health and wellbeing boards to drive that forward. Targeted prevention, starting with diabetes, which is one of our biggest risks, and then additional support to get and enable folk to stay in employment, particularly around actually mental health. Simon's been passionate since the day he was appointed around making patient empowerment real, investing in self-management, self-care and so on, and that's going to be crucial if you're going to get people to actually sign up to take much more responsibility for their own health. And again, as part of that, finding different ways, particularly through commissioners, to engage with communities and the voluntary sector. So huge, really challenging agenda about getting serious on prevention, but crucial if we're actually going to start to close the gap between demand and resource and tackle inequalities. New models of care, which is where much of the initial interest and reaction to the forward views focused. There seems to be, I think, a pretty wide consensus now that new care models need to manage networks of care, manage systems, not just focus on organisations, deliver much more care out of hospital, whether that's in relation to frail older people or learning disability and autism, where we have a massive challenge. Integrating services around the patient, not the organisation. Learning much faster from the best examples and then actually rolling those out. We've got to get much better, much smarter at dissemination and adoption, and then making sure we actually continually evaluate the new models of care to make sure they deliver both improved outcomes and value for money. Being optimistic, there are actually already examples of where the NHS is doing this and doing it well, but they're too few and people tend not to learn from them. You know, one of the depressing things about the NHS is the not invented here syndrome, which tends to be a major challenge to innovation, and we just need to get over that. If it works somewhere and it looks that it's transferable, then we need to encourage folks to actually look to adopt and adapt locally. So the answer isn't one size fits all, but it isn't actually letting 1,000 flowers or even 100 flowers bloom. We need to work out actually what's a sensible menu and then enable people to actually choose from the menu and drive it forward successfully. So that means working with local health economists, with yourselves, to consider the new options and actually then enabling you to drive it forward by nationally focusing on removing the barriers, working with our regulatory colleagues. New deal for primary care, one of the major new care models. We're in a situation now where we've got stable core funding for the next 2 years. On commissioning, we're committed to substantially increasing CCG influence over the commissioning of primary care and specialised services, and I think there's a real opportunity there for local commissioners with NHS England. We do need to make more progress on tackling inequalities, so looking at new incentives around that, and building the public's understanding of this agenda, again to help reduce demand. Those of you who've seen the poll in the HSJ today, really intriguing debate in terms of who's supporting some of the new care models. Multispecialty Community Providers, What are they? They're all about actually scale and scope of services, about moving away from traditional boundaries, about actually targeting services for registered patients who've got complex needs. It's about expanded primary care leadership, making the most of digital, as I said, is something we've got to drive forward on, and much more convenient access for patients. How do we think they could work? Well, we think larger GP practices could bring in a much wider range of skills. It's about shifting outpatient consultations and ambulatory care out of hospital in a way that transforming community services intended to but never actually really achieved. At scale, it's the potential to own and run local community hospitals, delegated capitation budgets and so on. And again, NHS England with the regulators needs to take seriously reducing the barriers to change. But I think some real opportunities to improve care and outcomes and accessibility through multi-specialty community providers. New models in primary and acute services to vertically integrate, looking to actually provide list-based GP and hospital services plus mental health and community. Certainly something that a number of foundation trusts have expressed real interest in. To do that, we'll need actually greater flexibility for FTs to invest their surpluses. There'll need to be some kickstart investment, and we need to make significant contractual changes to actually enable this. At their utmost, then they could develop into accountable care organisations. Again, I'm aware I won't name them, of a number of organisations, acute, but also some spun-out community providers who are doing some really interesting early work on ACOs. And I think that mix of accountable care organisation meets outcome-based commissioning could really drive forward change. Other new care models around urgent and emergency care networks, and also, as you know, looking to reform specialised care, consolidating services where there's good evidence for that, working with a smaller group of lead providers, but moving towards actually specialised centres of excellence for the rarer diseases. So basically, this amounts to wholesale change across the system. Drive up quality, drive up value, provide genuine integration for services for patients, and start to actually really address inequalities and the differentials in outcomes. As part of this, well, looking actually, in fact, to sustain local services where they provide the best clinical solutions and they're affordable and they have commissioner support and community support. So again, looking to enable that by adjusting payment mechanisms, looking at new organisational models, which I've alluded to, maternity services, commissioning a review of future maternity units for next summer, looking at actually how we can ensure funding supports choice in maternity, and again, enhanced care in care homes. So it goes back to, this is a wholesale review, change, transformation of care models across core GP, broader primary and community, acute specialised services. So fundamental change for the NHS to drive up quality, to get better value, and to give us sustainable models for the next decade. In terms of implementation, well, to do this, we're going to need new types of partnerships. What we're looking at doing is detailed prototyping of the new care models, developing a shared methodology so we can assess the local choice, the characteristics of health economies, making sure that there's national and regional expertise to support you to implement at pace, commissioners and providers, that we get much greater flexibilities in terms of the regulation of the system and a new investment model to pump prime. So we are also serious around enabling and supporting implementation to drive that at pace. In terms of innovation and change, aligning NHS leadership, developing a modern workforce, so key to delivering this, exploiting the digital revolution, easy to say, but huge potential around actually supporting self-shared care. And this will only work if we can, accelerate innovation and get innovation to happen in much shorter change cycles. So we want to actually then test bed and then roll out. We need to find a way of accelerating innovation. Efficiency and funding, well, you're all aware of the gap. The only way realistically of delivering that, meeting that gap, is to take concerted action on demand and on efficiency and on funding. On efficiency, with the upfront investment and the implementation of new care models, the strong belief is that we can achieve 2% efficiency gains, rising to 3% in the next Parliament, but that is a massive ask for the NHS. It should be doable. We have to do it in terms of actually rebalancing demand and resource. So the next steps: continue the engagement with you, with NHS staff more broadly and our partners nationally and with local authorities, refining work on outcomes and national work programmes, designing a delivery programme that supports you in implementation at pace, and then building system and particularly commissioning capability, which is why I wanted to go on and talk about actually some of the things we need to take forward in terms of commissioner capability. So that was it really in terms of the forward view, an awful lot to deal with in a short time. I'm very optimistic. I think if we can deliver even half of what's in the forward review, we will potentially have a huge impact on driving up quality, driving up outcomes, improving patient experience and ensuring the sustainability of the NHS. So I think Simon has laid out a very bold vision for the NHS, and we need to back behind him in terms of implementing it. I then want to talk a bit actually about some of the challenges and priorities in developing commissioning. I'll do it fairly briefly so we allow time for questions. Again, the forward view set out some pretty unprecedented challenges for the NHS around demand, public and political expectation, the resource gap. Why are we investing in looking at new models of care? Well, it's because it's fairly blindingly obvious that most of our service models across all the sectors are out of date and overstretched. And we know we've got persistent, unacceptable variation in outcomes across the country and internationally, in access and value for money. And don't take my word for it, just go back and look at your commissioning for value packs and the atlases of variation and right care. I mean, we've got the way of addressing it. It's something that commissioners and CSUs need to put their backs behind over the next couple of years. So given those challenges, yep, we need new models of care, and that's what the forward view says. And we need to transform services and, in the short term, drive up outcomes and value. The only way, from my perspective, with a commissioning system we're going to do that is if we've actually got great innovative clinical commissioners backed up by an excellent and aligned commissioning system. And I think that's the big challenge for us, for those with an interest in commissioning and commissioning development. So what do I think would get us there? What would give us great innovative local clinical commissioning and an excellent commissioning system? It's a package. None of these key enablers in its own right will do it. So we absolutely need really good, credible, energetic clinical leadership. That's what the reforms principally were about, not about the competition stuff in the market. It was actually about getting clinical leadership, empowering clinical leadership in commissioning. So that's, a prerequisite. The second thing we need, though, is commissioner synergy. So we need really effective co-commissioning, for example, in relation to primary care, joint commissioning. One of the areas I'm currently working on supporting is what do we do about actually what's known in inverted commas as the Winterbourne cohort. Those actually, in fact, with severe acuity in terms of learning disability, autism with very challenging behaviours. We need to transform the system so we actually flip it over from being largely institutional-based care to intensive community support. That's not going to happen without actually effective joint commissioning between NHS England, CCGs and local authorities. So that feels absolutely crucial to the future. I would say this, but I think CCGs and local authorities need to be supported by excellent commissioning support, and I'll talk you through what we're doing on that. There's no point in just, however, actually tinkering within existing contracting models. So again, I passionately believe that commissioning for outcomes which is not the same as outcome-based commissioning. So this is actually about saying that whether we're looking at our 2 or 3 year contracts with acute providers, we need to put as much energy into building outcome measures, incentivizing improved outcomes there, as we do in looking at actually population-based initiatives, say for frail older people, end-of-life care. And we need to grasp that. Commissioning for health and prevention, again, one of the 3 key areas in the forward view. Commissioning for new models of care, that again won't happen by accident. We'll need new skills, new models, and quite a lot of change from us as regulators. And then lastly, effective market development. If we're going to have new models of care and bring providers together in different ways, that can't happen chaotically by accident. Commissioners need to play a very active role in thinking through what do they want from providers, what are the behaviours they want to incentivise, and then stimulate the market to deliver the new models of care we need, where you've got at scale integrated, aligned and allied providers. And again, that's where outcome-based commissioning, models like prime provider, but also actually alliance contracting, maybe for things like learning disability, I think have got quite a major role to play, not as ends in themselves, but actually as key vehicles. So those I see as being the key enablers we've got to, between us, get in place if we're actually in fact going to deliver the potential of the forward view. A little bit around primary care co-commissioning, emphasised in the forward view, which I think is great. I see co-commissioning as being a key enabler in developing seamless, integrated out-of-hospital services based around the needs of local populations, as well as driving new models of care, like multispecialty community providers and the changes in primary acute I talked about. There are 3 models that CCGs can take forward, and a lot of engagement going on around that. Why is that worthwhile bothering with? Well, I think it's because it could lead to substantial benefits for the public and patients, certainly around improved access, around actually improving the quality of out-of-hospital care, outcomes, equity, reduced inequalities, and crucially a much better patient experience. So I think there's a lot to play for in getting primary care co-commissioning right, but it can only be done as a partnership between CCGs and NHS England. Commissioning for outcomes, my personal view is that if we're going to deliver on the forward view, then we need approaches which do these things, which incentivise high-quality integrated pathways, which deliver high-quality joined-up care. I mean, that's the essence of the forward view. What is encouraging is we're starting to see, I think, a tipping point, particularly around actually MSK with recent contracts. We need to see an approach around commissioning for outcomes which are place-based with effective co-commissioning. Goes back to my comments around actually we need to avoid fragmentation from multiple co-commissioners, and some of the methodologies around commissioning for outcomes should enable that. It's about making the best use of resources, not just NHS, but local authorities, communities and users. And I know it's now being replicated across the country, but I really like the phrase that Leeds came up with a year ago, which is there is only one Leeds pound, that actually got folk then to aggregate around that in terms of making the best use of resource. We've got to find ways which reward the delivery of the best outcomes for users, carers and communities, and that, I think, it means commissioners taking seriously, along with providers, social value, and so far that's often been a token nod towards social value. We need to make that happen. We've got to address the demand risk explicitly, which means CCGs have got to think quite carefully around their contracting models. We need to find ways of catalysing providers coming together in different combinations to deliver new models of care, and we need to include not marginalised non-NHS partners, particularly the voluntary sector. We have a long way to go, I think, in developing real partnership working with VCOs, but they're crucial to effective delivery of patient support, community engagement, prevention and so on. So we're missing a huge trick if we don't do that. Hopefully you know this stuff. Outcome-based commissioning, I mean, it's I see it as actually being one end of a spectrum of approaches. At the other end, so we're not talking population-based, I think there's a huge potential to drive change quickly in secondary care around using approaches such as actually ICOM. So that's very much linking payment much more closely to clinical performance. The major insurers in the States are using this approach. I think it's quite a high degree of credibility, and I think those commissioners that actually are able to translate that into something where you can then use it in your contracts to drive up quality and outcomes will make huge progress. So that isn't about the big 2 or 3 year time lag population stuff. This is actually about embedding clinical outcomes in contracts and actually incentivizing, increasing the proportion of payment that's linked to that. And frankly, I would strongly advise commissioners and consultancies to plagiarize some of this because there's a really good evidence base. This just gives you an example of the ICOM standard set for localized prostate cancer outcomes. I won't go through it, but you can start to get the sense of actually how you might turn this into something you might contract for. Moving on, Bedfordshire Clinical Commissioning Group developed an outcome-based contract as part of their work on MSK using the ICOM lower back pain, so it's certainly doable. So my strong recommendation to CCGs and CSUs will be to take seriously the potential to use the ICOM measures to embed clinical outcomes and gear up, use those from 16, 17 onwards.
Just to interrupt there, if I could ask anyone who's dialed in on the phone, please could you put your phone on mute? As we can hear a bit of interference in the background. So if I could just ask you to put your phone on mute whilst Bob is presenting. Thank you.
Yeah, okay. 4 p.m. on Thursday, that's fine. Yeah, that's great.
Okay, I think we're fine now. So I'm not going to go through the diagram in detail. I would refer you, there's some very good work done actually by the Commissioning Assembly Quality Working Group on trying to define what actually commissioning for outcomes might look like, making the point around it's a spectrum. Would refer you to that. Just picking up on core outcome based, what are the key features of the model? Well, outcomes. But the key thing for me, where I've seen outcome based commissioning work and fail, is where people have either actually not put the effort into identifying the right outcomes and they're measurable, but actually they're not thinking through, well actually if these are the outcomes I want, what are the behaviours I want in the system, and then linking that through to incentivising those through the payment system. And I've seen folk who come up with quite good outcomes, but then hit problems around actually, but they've not done the work around behaviours. I've done both of those, but actually they're not thought through how they're going to get the incentives right. Now that isn't an argument for playing around with incentives and contracting models and the pros and cons of prime provider, prime contractor alliance at the start, but it is actually about thinking through what do you want to change, the hearts and minds stuff, how do you change behaviours. It's got to be at scale, and it's got to be about actually encouraging much more mature and longer term relationships with providers, so 5-7 year plus contracts, but you're only going to make that progress if there's a sufficient degree of trust in the health community to do this. If not, you may need to focus on building trust. There are two main types of models, lead provider, alliance contracting. I'm not going to talk about those in any detail. Lead provider can then be split down into actually prime contractor, prime provider. The best bit of advice and analysis I've seen in the last 2 years is the King's Fund review of actually the two, prime provider, prime contractor and alliance, and I'd actually, if folk want to explore these contract models, have a look at that. I'll move on. The nice thing is I think we're getting to a tipping point where I'm starting to feel confident that in terms of commissioning for outcomes, there are enough folk out there being brave as commissioners. A lot of it's around MSK, so you've got Bedfordshire, which is a really good example to actually look at. If you want to actually do outcome-based and transformation around MSK, the work of Cambridgeshire and Peterborough around a range of services for older people, particularly the engagement there of actually the third sector. Staffordshire, around cancer and end-of-life care, hugely at scale, $1 million plus, quite controversial. That's a prime contractor model, which is really innovative, so worth looking at. Lots of material on their website, Macmillan. Really the whole of Sussex around MSK. Huddersfield and Kirklees went out about a week ago on a community services lead provider, and you'll be familiar, slightly older, the work that Oxfordshire and Milton Keynes did around testing outcome-based commissioning in sexual health and substance abuse. So we're starting to get to the stage now actually where we're starting to see some proof of concept and where this isn't seen as something that is largely of academic interest. So I find that quite encouraging. There's a big upside, I think, in terms of delivering transformation and care coordination. There are loads of urban myths around this. It doesn't preclude personalisation and choice, and it shouldn't freeze out voluntary sector, SME participation. You can do that through subcontracting, but some folk manage not to. I will move on because we're running out of time. I just want to say a little bit about commissioning support. We see getting in place good, strong commissioning support as being crucial for this. We are absolutely sticking to the goal we signalled about a year and a half ago, that it's really important that every commissioner can access excellent and affordable commissioning support, but they get to choose. We've used the creation of a market to actually do that, but it's very much a managed market, not a free-for-all. Three key cornerstones. One is developing CSUs and others integrate providers. A lot of consolidation. We're now down to 9 CSUs plus a range of commercial providers. The risk of actually upsetting CCGs, we need really intelligent, informed clients. So a lot of work with NHS clinical commissioners and groups of CCGs around reviewing their make, share, buy decisions, gearing them up to use the lead provider framework, and then the lead provider framework procurement, which is progressing fast. What is it? It's a call-off procurement framework that includes all of commissioning support. If you're a CCG, you can buy whatever you want, as little or as much, through short, simple 2-month mini competitions from February. Use of the framework is voluntary, but lead providers are being robustly quality assured, having looked through all their bids and assessed them. We are taking quality very seriously. We've set a very high quality threshold, and it will open for business in February. Not going to go through the lead provider framework in any detail. I just wanted to mention one thing, which is the Dalton review. You really, if you're a commissioner, shouldn't overlook the Dalton review. One of the key enablers I talked about for commissioning was the need for commissioners to get much more involved and effective in market development. And I would strongly advise any commissioner to keep a weather eye on the implementation of the Dalton review. Came out in the last week, really very radical in terms of saying, and again it's created pretty strong consensus around we need new organisational responses, new options to reduce variations in standards in providers and help implement the radical new models of care under the forward review. Quite a wide range of options being considered. Hospital training, which has been something that's been discussed for 2 or 3 years but is now a recommended option. Hinchinbrook-style management franchises, Moorfield-style service-level chains, which I have to say, having experienced Moorfields, absolutely brilliant protocol-driven clinical service. That set the model in terms of eye care. There are other service-level chains that I'm sure can be developed. Federations, FTs having JVs to run management contracts with other FTs, with the independent providers, with BCOs, with social care, huge range of options there, integrated care organisations. So I think really exciting if you're a provider, but I think commissioners, and us if you like, as those with the responsibility for the commissioning system, need to think really quite hard around, so what are the implications of those types of developments for commissioning and commissioners? So as not to miss a trick, but also to ensure that actually commissioners do drive change. Now I say that because the Dalton Review recommendations are that it should move very quickly, so that actually, in fact, if folk are merging, doing JVs, it should be completed in a year or less. That Monitor and CQC should establish a new credentialing and accreditation process for organisations. First wave to be accredited by October of next year, and then can register on a procurement framework live from April 16, which Monitor and TDA can then use to find support for challenged organisations. So this is really serious stuff. If you go back to look at those options, they're pretty radical. They can have a huge impact for good on the structure of the provider market, but commissioners, local and national, need to think through actually what are the implications and how am I actually in fact going to make the best use of those opportunities for my population. I'm going to stop at that point because it would be great to get some questions. So I'm going to hand back to the organisers. Slides, I think, are downloadable or will be?
They will be, yes, after the meeting or after the webinar. So, as I mentioned at the beginning, we'll take the phones off mute now for the time being so that you can ask questions of Bob directly. We do have one that was sent through, and that was just in relation to a copy of the presentation, so that will be available afterwards.
Can I just say that, I mean, there's nothing in the presentation that you can't share more widely. So we'll make it available, but if you want to use it with your teams, feel free.
All guests have been unmuted.
So please do ask questions if you have any. We've had a couple in by email, so Bob might run through one or two of those.
Okay, well I've done one of them, which is actually the Dolphin review, which is, yes, I do have comments. I think it's really exciting. It feels absolutely right in terms of bringing together options for restructuring the provider market. I just think commissioners and regulators need to think through the implications, but I think it's great. One of the other questions was, well, does the 5-year forward view promote outcome-based commissioning? Well, yeah, it absolutely does. Both in terms of commissioning for outcomes, in the shorter term stuff, but if we're actually going to implement new models of care in the way that actually Simon Stevens has set out, we are going to have to come up with new models for commissioning and contracting that actually can deliver that. So I think it plays absolutely into population-based, outcome-based commissioning. I think it plays into the various models, prime provider, prime contractor, even alliance for things like actually learning disability and autism, where we need to do major transformation. So I think it absolutely supports and promotes outcome-based commissioning and commissioning for outcomes more generally. So, but I'm very enthusiastic about it. I think it will create some real momentum behind this. Okay. In terms of what reform to the payment system is needed, are capitated models and year of care models the only way? No, I don't think they are the only way, but I think enabling capitation type models is really important. Year of care, I think, can work for some conditions. I'm not a great fan of it. If you're not careful, it can become very over complex. But yes, I think we need to accelerate progress around capitation. One of the questions I was asked, well, what's my reflection on Monitor's attitude to capitated funding? Well, I think it's great that Monitor's getting into that space, but we all need to actually, in fact, make more progress and enable that. I think there are practical things we can do, because the choice of models very much got to be down to local communities around making sure that our approach to contracting, our advice and so on is flexible enough so you can then take models off the shelf and adapt them locally rather than 211 CCGs reinventing the wheel around that. But I think the signals from Monitor around actually capitation are really encouraging, but it's not the only. You're absolutely right, Philippa, it is not the only model. Do I actually, in fact, have any more information on the viability of hospital modelling and analysis of the NHS England? I think, Jade, if you could narrow down the question a bit, it's not me trying to duck it, then I will take that away and see what we've got. There's a fair amount of modelling, as you might expect, that's been done already to support the preparation on the forward view. So if you could let me know exactly what will be particularly helpful to you, then I'll go back and discuss it with the Endodges team. But I just need a slightly narrower question, if that's okay. But if you can either let the organisers know, and I'll come back to you next week with what we can share or not. And obviously, if it's a broader interest, I'll rely on COBIC to let me know. We can share some of that. It's all gone a bit quiet. Oh, we've got another one. Yeah, okay. So best practice around incentivising local pricing will be really helpful to commissioners. Difficult to get acutes off PDR. I mean, my sense is that the monitor attitude is changing there, but we've got a long way to go in terms of, the behaviour of many acute providers on that. Single source of best practice. That's something that I can ask our contracting team to have a look at. I think that's a really good suggestion. So my strongest advice would be, and it's something we're exploring with the contracts team and others actually later in the week, is how we could quickly make a reality of the ICOM stuff so you can actually do what some of the insurers have done in the States and embed serious clinical outcomes to incentivise in the existing contracts. But I'll take that away and talk to the contracts team at NHS England around, well, can we actually make sure that the advice to support the business planning for next year is brief and focused. So I'll take that away and I'll come back to you, Patrick, around actually where we go on that.
Bob, could I ask a question? Can you hear me?
Yeah.
Final 30 here, since you know I'm a GP in Cambridgeshire and Peterborough. So it's really a central thinking about GPs as providers, and it strikes me that if we're going to get change of pace, we need to think about ways of bringing them in as providers into whichever organisation or solution, accountable care organisation, ICOs, alliance contracting. They need to be there with their voice as effectively as possible as providers, but that's quite difficult to see a path for that.
Yeah, I mean, I agree with you. I think it is. I think it's essential if we're going to deliver on this agenda. One of the key challenges in the forward view is, well, how do we do that? There are various proposals in terms of the approaches to new models of care. It's tricky, as you know, but it's not impossible. So that's one of the key development areas we want to look at in terms of how can we actually, what advice can we give around for those folk who might want to fast track that. But I agree, crucially, you can't make the sort of models work that we want to in terms of real integration and that focus on prevention, admission avoidance and so on, you know this in Cambridge anyway, work without actually having GPs and broader primary care at the core. It feels an absolute prerequisite.
Thank you.
Interesting question around actually local patient level data collection to support capitation calculations. I'd agree on that. Part of my experience would be around evaluating some of the attempts on outcome based, and certainly some of the work that Staffordshire's been doing is the most sensible way of actually doing that is to frankly just accept that you're not going to actually have accurate data and the right range of data in the first instance, and therefore you need to be clear on your direction of travel around capitation, but agree a sensible approach to actually sharing risk between the providers and the CCGs in the first couple of years. I think it's really dangerous to leap in, do your capitation calculation and assume it's right, and then hold providers to account around the demand risk. You may be being unfair to them, but equally you could actually be being over generous. So I would strongly recommend that actually the first year or so is very much around testing out the data, making sure you've got it right, that you understand what the implications are, because it may tell you rather a different story in terms of what's really happening to demand as against what you think is happening to demand. And there are a number of methodologies around from some of the sites in terms of how you can come up with a fair and reasonably prudent approach to actually risk-based. And that was certainly some of the advice from Monitor at a recent conference. Don't leap in and allow initially the providers and commissioners some degree of wriggle room whilst you sort out the data you need. Sharing what's worked well. I keep on lobbying folk on this. I mean, we've made some progress. The Commissioning Assembly publication shares some material actually on what's worked in terms of known sites. COBIC, looking at Carol, I think, were looking to actually publish some material on their website. NHS Clinical Commissioners, likewise. I'm very happy to share the material we've got in NHS England around in terms of outcome-based commissioning, so the population-based stuff, who's doing what stage are they at, because I think it's quite unhelpful just to know that Staffordshire is doing end-of-life care and cancer. You need to know, well, how far have they got in it, what's worked well, what doesn't, and so on. And we're still not as good as we should be nationally, both ourselves and some of the national organisations, in sharing that. And if we really want to get folk to drive forward things at pace, we need to share that more effectively. So I'm happy to share what we've got, but I'm pretty sure COBIC's got some material available as well.
Yes, we should do, and we, at the moment, as you know, are updating the COBIC Club microsite, so hopefully within the coming weeks we'll have some materials that are available just for COBIC Club members as well.
What we'll do, because I think it will be sensible to actually, in fact, just I'll share with COBIC what we've got in NHS England around that, at least make sure that we've got the same list of who's doing what and that it's accurate. And where we've got website links, I'll share those so that you can either go via us or you can go via COBIC, so at least we've got a couple of sources of who's doing what and how far they've got. But really would strongly encourage folk to share experiences and learn, as much, frankly, learning actually what folk got wrong as actually what's going well. And so, sorry, NHS Clinical Commissioners have got some good stuff, I think, on their website now around looking at what key enablers are and the sort of things you need to think about before you go anywhere near outcome-based commissioning.
Do we have any more questions at all?
You've got 3 minutes left, so, you know.
Okay, so I think we'll wrap up there. I hope you'll all join me in thanking Bob for an interesting and insightful presentation today. And likewise, we would like to thank you for participating and particularly for your questions. As Bob mentioned at the start, if there are any further questions, please do feel free to send them across to us. You have my email address. It's katrina.darling@cobic.co.uk. And we'll do our best to liaise with Bob and get some answers and materials over to you where we can. If you have any suggestions in terms of topics for our webinars or workshops, you're always welcome to send those to us through to us as well. And I think the most important thing to point out to you at this stage is we have our date for our first COBIC Club webinar of 2015. It will be the 20th of January in London. It will be an all-day event, and we're very pleased to have secured our speakers already. So we have Rachel Adcock from the King's Fund and Catherine Mountford from Oxfordshire CCG, who will be presenting and helping to facilitate the workshops on the day. So we are taking registrations. Please do let me know if you'd like to register, as we do have a minimum number of places available. So just send me an email or give me a call, and we'll get you registered for the day. I mean,
I've got no commercial interest in COBIC, but I'd strongly encourage you to go, not least because the King's Fund is the place I look to academically for who's actually done some rigorous work around the different models, the pros and cons of OBC. So COBIC have got a really good speaker lined up for the day. So even if you just come for her, frankly, you should.
Thank you, Bob. And again, thank you for your participation today, and please do send any emails or feedback straight through to us. Thank you.